My name is Stephen Lewis. I'm a paediatric neuro-oncologist from Bristol Children's Hospital. My colleagues here are all neurosurgeons involved in the neuro-oncology service, and I'm now going to describe to you the development of a system which we have for convection-enhanced delivery for patients with glioma. So first I'm going to describe what convection-enhanced delivery really is, and explain why this is relevant to tumours such as DIPG. I will go into some detail about how we developed the delivery system in Bristol, this being built on work done in Parkinson's disease and then subsequently in adult patients with brain tumours, leading on to our clinical experience with carboplatin in children, and hopefully explain why this is a really excellent opportunity for developing new clinical trials in DIPG in the future. So this is the clinical problem. This is a patient with DIPG with extensive involvement in the region of the pons, extending up into the midbrain and down into the medulla, and also into the superior cerebellar peduncle. So an unresectable tumour for which we have very limited options. And the outcome, of course, is very poor. Even with conventional therapies, we really have very marginal benefit. We do, of course, have new biologically driven phase 1 and phase 2 studies coming through, but none of these have been shown to improve outcomes at the present time. One of the problems that any new agent has is being sure that we are able to deliver the drug to the right place, and direct delivery may be one means whereby we can be sure that we're delivering appropriate doses of drug to the tumour itself. So if we're trying to deliver drugs straight to tumour tissue, there are a number of factors which we have to take into consideration. The first being that it has to be delivered to the right place. Then you have to make sure that the drug entirely perfuses the tumour, so fills the entire tumour volume. You want to avoid causing local tissue damage, and ideally we want to be able to give this on more than one occasion without having to have complex neurosurgical procedures, since most chemotherapy doesn't work after a single dose. It requires multiple dosing to achieve the benefit. So I'm going to describe some of the factors used to deliver drugs and explain some reason why convection is really what we should be seeking to achieve with any delivery system. So I'm going to talk about injection, then diffusion, and then convection. So injection is what is normally done, for example, with an intramuscular injection of antibiotic, for example, whereby a needle is placed into the tissues and fluid is simply squirted into there. And when that happens, you force fluid into the tissues and you produce a cyst or a reservoir, which then slowly leaks out into the blood or lymphatics. So it's a very good way of delivering any therapy into the systemic circulation, but it's not particularly good at delivering treatment to the region where you inject it. The injection itself causes cysts. It is associated with reflux of drug along the tract of the needle. It causes quite significant injury and bruising, and there is clearly potential for a more serious hemorrhage if you happen to hit a blood vessel. So in general, simple injection is not a suitable tool for brain tumours. Diffusion is the process of distribution of molecules into other tissues, down a concentration gradient. And in the brain, this is something which is limited by the blood-brain barrier, which is characterized by many tight junctions and membranes which associated active transfer, which prevent drugs getting across. And even when you have simple penetration not being opposed by these processes, penetration is only possible up to about 2 or 3 millimeters before absorption gets into small vessels. So what we're really trying to get is convection, where you get bulk flow of fluids along a pressure gradient, and that means that the entire parenchyma, the entire tissue itself, is immersed in the solution of drug that you're trying to convect. There's no gradient of concentration within that area, and what you're really doing is replacing the normal extracellular fluid with whatever it is that you're infusing into the patient. And the final step of getting drug into the cells is by diffusion, but this is down a concentration gradient, but it is at the microscopic level. So I've done some animations just to show what this is in principle. If you imagine that you have an area surrounded by a circle where you have injected something, and this is your deposit of drug, and the long red wavy line is a small blood vessel in the tissue. Then with diffusion, what happens is that those molecules are gradually allowed to segregate, and as soon as they get to a blood vessel they tend to be absorbed, so you have whole areas which really don't show any significant exposure to the drug. And the concentration in the end, after diffusion, is relatively low. Now if you go back and do the same thing with convection, then what you have to imagine is that we're continuing to infuse drug as the convection process continues, so that as you proceed, more and more drug or fluid containing drug enters into the tissues. And this becomes progressively saturating the entire tissue, and although there will be some uptake into blood vessels, you will certainly get much greater drug concentrations in the tissues further on. So this is a much better way of delivering drugs into tissues. And the other way of looking at it is, if you imagine what the concentration of drug is as you move away from the point of your injection, then with diffusion you get a very rapid fall off, so that very small area is exposed to useful concentration of drug. Whereas if you have convection, then you may maintain a high concentration for a considerable distance from the infusion site. So convection is what we're trying to aim for: direct delivery into the brain parenchyma, which can bypass the blood-brain barrier and overcome those things which affect distribution to the tissues. We want to be able to target specific areas within the brain, and we also want to cause high local concentration of drug, but actually not very much systemic toxicity, because the amount of drug we're infusing is relatively small. So I'm now going to talk to you about how we've developed this system in Bristol. The project began in Parkinson's disease, which is a degenerative brain disorder associated with loss of cells which produce a drug called dopamine. And these are in this part of the midbrain called the substantia nigra, and as these cells die, so the patient develops shaking, they become very rigid, they lose spontaneous movement, and eventually they show signs of dementia. The treatment conventionally is to give people a replacement drug which takes over the function of dopamine. So oral dopa is taken, and that is effective, but it's associated with significant side effects, and it becomes less effective with time. This drug, which is abbreviated to GDNF, is a neurotrophic factor for the neurons that produce dopamine. So it stimulates neurons to make more neurons. And in animals it was shown to improve motor function, but a previous study in adults, when GDNF was injected into the ventricles, so into the CSF which surrounds the brain, showed no improvement. And that's perhaps not surprising if you realise that for drugs to get from the ventricles into the brain, it only happens with diffusion, and that can only happen to 2 or 3 millimeters. So this is the process that was undertaken by Professor Gill's team, whereby the putamen, which is one of the parts of the central structures of the brain, had convection of GDNF, and this led to new neural synaptic activity, and that in turn caused increase in dopaminergic signals going back to the substantia nigra. And this worked. So this is a tissue taken from a patient who sadly died after they'd finished treatment, and on the left hand side you have part of the putamen which was not treated with GDNF, and on the right is the corresponding opposite side, and you can see that there is very significant neural regrowth on the right hand side. If you look at function, and this is a PET CT scan, on the side that was treated, there was a significant increase in dopa uptake in the patient 2 years after starting treatment. So there is evidence of regeneration of neural tissue, and this corresponded to significant improvement in Parkinsonian symptoms, even when the patient was on no medication. So in this graph on the right hand side, these are the symptoms that a patient has when they're on treatment, and the higher the score, the worse their symptoms are. And you can see that without medication, each patient had significant Parkinsonian symptoms, and over time this gradually reduced as you got a return of normal function. So the most important conclusion that was identified from the phase 2 study was that chronic infusion does not give uniform distribution of drug, and this was shown very clearly in the picture that I showed you before. So this is the putamen of the patient who had been treated, showing regeneration. But what you can see is that there is an area surrounding the catheter tip where no regeneration occurred at all. And indeed this is down to there being too high a concentration of GDNF. And actually the regeneration occurs in a Goldilocks zone where the ideal concentration of GDNF is available before it is diluted by peripheral blood vessels absorbing it. So that was a problem with the initial mode of presentation. Slow infusions do not do what we wanted to do. The second important factor was that catheter size very significantly affects the way in which fluids convect. And this can be shown in this example of two patients who were convected using two different size catheters. In the first example, with a small 0.6mm catheter, there was good convection. With a larger catheter, what followed was very significant reflux, and that's because the larger catheter damages tissues on its way in and causes micro slits to open around the side of the catheter, and fluid simply refluxes and doesn't go where you want it to go. So catheter engineering is a really important aspect of this, and this led to a whole series of studies looking at different catheter designs. These are little gel examples whereby you get diffusion around the tip of this catheter, but then you see very rapid reflux occurring as fluid is put in. With a different catheter design, this wasn't perhaps quite so bad, but still very significant reflux was obtained. So the solution was rather ingenious and involved a 3-section catheter, which is called a recessed step catheter. And if you look at the tip of this, what you find is that there is an outer sheath, which is the guide tube, and then an inner catheter, and then finally the microcatheter in between that. And there is a lip here which goes down and then back up again. And the effect of that is to effectively do two things. Firstly, it eliminates the point source because some reflux does occur. So a point source would just be fluid coming out of the tip of the catheter like that. In fact, what does happen is the degree of reflux, fluid refluxes all the way back up to where the step is, and then it stops. But the advantage of that is that you end up with a much broader area of convection, which allows much more rapid infusion rates and much better convection of the tissues. So this is proven to be a very successful design, and that's what we use from this point onwards. And here's an example of convection using the recessed step catheter, showing very neat, very well controlled convection without any evidence of reflux at all. And you'll see some pictures elsewhere, for example here, where a catheter is inserted into the putamen on two sides, and an MRI is performed when the patient has had gadolinium, which is contrast medium, injected, and you can see that there is no reflux, and all of that gadolinium is perfused into the area that's targeted. So the next component of convection is that precise location is absolutely essential. And to do this, there's been a considerable amount of work in developing a specific robot to allow catheter placement to be guided very accurately. And in conjunction with this, there has been custom planning software. There has been all sorts of other additional projects, including automated structure recognition, so that the computer will identify automatically what is needed to be targeted, and linking of MR angiograms before any surgical procedure is performed. I'll just show you some examples of these. So here's the robot, and this is the software typically used to control the machine, with, you can see in this patient, a planned trajectory of one catheter going into a brainstem tumour. The collision avoidance component is very important. It's very important before you do your first part of an operation to be sure that you're not going to strike a blood vessel on the way. So MR angiography allows the surgeon to choose the pathway which is going to avoid any major vessel and indeed any minor vessel all the way down into the target area. This is Professor Gill and Mr. Barreau, and these are some examples of the implantation for patients with Parkinson's disease which have been performed. So this is an axial section of a patient with Parkinson's who's going to have implantation of a catheter, and this is the area that's being targeted, and this is the first catheter going into one putamen. And on this other section you can see a similar placement. The accuracy of this is remarkably high. So in all of the studies that have been done, the mean error of positioning of the tip of the catheter right at the very end is 0.7 of a millimetre, which is much greater than can be expected by any other mechanism. I'm just going to show you this in a little more detail to demonstrate precisely how accurate this process is. So here we have a sagittal section, that's a side-on view of the brain, of a catheter going into the basal ganglia again. And what you can see here is the larger catheter, which is the introducer, within which there is a microcatheter which proceeds from the tip of the introducer to the end of the perfusion area. And this is the target volume that is being perfused. If I expand this area in a little more detail, what you can see here are a number of black dots, each of which are blood vessels, and you can see very clearly that the catheter is passing in between these blood vessels, and indeed in some areas it's actually physically in contact with the blood vessels. So in all of the catheters that have been placed, and we have well over 100 catheters placed at this time, there has been no surgical morbidity of any description, and in particular no hemorrhage. So the final component that's necessary to deliver this system is the ability to give repeat dosing. And to do this, Professor Gill's team have developed a very neat package. So here's an example of the system in operation at the present time. This is in a pig who has received convection enhanced delivery of gadolinium, so contrast medium, on 4 separate occasions over a period of 4 months. And you can see that the basal ganglia are very clearly highlighted after 1, 2, 3 and 4 months, and essentially there is no difference in the distribution of these over that period of time. In order to do this, it's been necessary to develop a stable platform for delivery, and this is what finally has been developed. This is a transcutaneous bone-anchored port developed on the back of technology used for implantable hearing aids. So what you're seeing here is something which is the size of a small fingernail, which is implanted into the bone, and out of which comes 4 separate microcatheters under the skin. The top of this has a number of markers which allow a specific clip to be attached to it, and that connects up to the infusions. And so here's a cartoon just to show you exactly what's going on. We have specific catheters connected by this lump behind the ear, and each of these catheters go to specific catheters which are permanently implanted into the central brain. There's another example of a patient who has a catheter in situ with a small celastic cover over it to provide a little bit of protection. In fact, these barely need any additional protection because even in pigs they don't get infected. But the great advantage of these is that the patient can go swimming, they can do any normal activity without any concerns. This is the same connection connected up for infusion, and this is the little girl who is going through the process of having it connected on the ward. And my thanks to Daisy's parents for allowing us to use these pictures. So, we have a system which is able to work on more than one occasion, and now we need to find a drug that's usable. So our work so far has been principally using carboplatin, and the reason for that was that carboplatin is active in glioma, It's used extensively intravenously and in high dose, and sometimes intra-arterially to try and enhance the delivery to various tumours. We had extensive preclinical studies of convection in animals, demonstrating that this was well tolerated, and in particular found very mild side effects at very high levels of infusion. And we'd also had developing experience in some adult patients with glioma, and I'll show you some of the examples of these treatments later on. So the first question is, does carboplatin have activity in glioma? And the answer is yes. And here's a patient who has a glioma here. This is the tract of convection enhanced delivery, and this is the glioma 3 months later. Now this was a patient who was treated 2 years ago, and that would be a truly remarkable event were it not for the fact that this was in fact a boxer dog. Boxer dogs are very prone to developing gliomas, and a request was made for us to treat somebody's pet, and so therefore this provided an ideal opportunity to demonstrate efficacy. But this animal is alive 2 years later. This is a patient, so a human patient, who had recurrent glioblastoma. This was a patient who had an extensive tumour which had already been resected. It was surgically cleared very well, but within a month had already shown signs of recurrence. So normally there wouldn't be any modality available to treat such a patient who'd already had chemoradiotherapy. So this patient had 4 catheters inserted, and here you can see the 4 catheters coming in from different angles. The area in red is the anticipated fluid volume after infusion. And the situation by the time chemotherapy was started was worse than I'd shown you previously, with further growth of the malignancy. But 3 months after that single injection, what you find is significant reduction in the size of the tumour. So there is clearly evidence of activity of carboplatin in gliomas in general. The next step for us was then to extend this to paediatric patients, and in particular to patients with diffuse intrinsic pontine astrocytoma. To do this, we had to be sure that we were going to cause no harm. We made a point of approaching both the clinical and the research ethics committees of both trusts where such patients might be treated, and we had general support from them. But we made it clear that treatments would have to vary because we were still learning about how best to treat these patients. So this was not a clinical trial, these were pilot studies whilst we learned how best to infuse treatments. So this is the first patient who was treated, who had a large diffuse intrinsic pontine astrocytoma, and the volume in red is the area which was effectively convected by a single catheter. So here are the results from our first 7 patients who were treated, all of whom had significant, large and progressive diffuse intrinsic pontine tumours. Pre-treatment was similar in that all patients had had radiotherapy previously, and some had had chemotherapy. The interval from diagnosis to the start of treatment was, in the first instance, very extensive. More recently, we treated patients sooner after treatment. The first patients we treated had catheters made out of fused silica, and all subsequent catheters were made out of material called carboplatin, which is of much lower friction and less likely to block. The latter 3 patients here all had the port system implanted so that they could easily have multiple infusions of chemotherapy, and that is now going to be the platform for which all subsequent patients will be treated. Although there was one patient right at the start who had 3 separate operations with 3 implantation of fused silica catheters, and the reason we did this repeatedly was because the patient experienced very significant benefit from the treatment. If we look at the volumes of fluid infused, substantial amounts of fluid were infused, up to 22 mils, and generally we find that for every mil of fluid infused, this will cover a volume of tumour which is about 3 times larger. So 22 mils would be expected to cover a tumour which is of approximately 60 mils in size. But even with these large volumes, the amount of chemotherapy infused is minimal. Total dose of 4 milligrams of carboplatin would not be enough to cause any toxicity at all to a patient with a normal marrow. So this was the transcutaneous port, as I explained, and here's an example of what is going on underneath the surface of the skin. So what we have here are 4 separate catheters attached to tubes going to a central hub, and then that hub is connected to the transcutaneous port where it can be connected. On the right we have a picture of a representation of the tumour with the catheters going in at different angles, just simply to demonstrate how we're attacking the tumour from different sides. And that's just another representation of the same thing. On the left here we have a similar representation with the red showing areas where fluid is expected to convect to, and so you can see that we're recovering a significant proportion of the ponds in this particular patient. And on the right we've overlaid the angiogram to show just how complex the anatomy is at this site and how important it is not to go in blind in any way, to have a very clear trajectory for any catheter that's going in. I'm now going to show you some cutaway views. These are MR images from a patient, from a patient who was undergoing insertion of catheters. This is the volume of the tumour in green. There is a cyst within the tumour, and that is identified in blue. So the first catheter was placed transfrontally, second transfrontally from the opposite side, and you can see that these are sort of crossing as they come in. The third catheter was placed from the cerebellum and approaching the inferior side of the tumour, and the fourth from the opposite side, approaching the contralateral side of the tumour. And in addition, a catheter was placed into the cyst itself, which meant that we could then drain the fluid and reduce any swelling associated with the procedure. So this is an anticipated fluid convection volume coming from one single catheter. And that, of course, doesn't cover the entire tumour, but it covers a reasonable volume. This is the volume from the second catheter, the third, and the fourth. So the combined volume here covers nearly all of the tumour. And this is just an example of how one might proceed, rather than an attempt to demonstrate that absolutely all of the tumour is covered. And then, just returning, if you then drain the cyst, the blue volume is reduced somewhat as the fluid is removed. And that's a further example of how cyst drainage occurs. So here's an example of a patient who has had successful treatment with a tumour which had been previously treated some time before. It has significant edema and reduction of this, and a minor reduction in the overall volume of the tumour. So this was consistent with the patient's clinical condition, which improved over this period. And again, 3D representations of the size of the tumour showed a very minor reduction in the size of the tumour, but more importantly the patient was less dependent on steroids and generally better. So that's really as far as I want to go at the moment. We think in Bristol we have the largest experience of clinically used convection enhanced delivery. In fact, 170 catheters have been inserted over the past few years. In adult patients, over 100 infusions have been done as an outpatient, so the patient arrives and leaves on the same day, and there has been no surgical morbidity of any description from these procedures. The platform and the system we've developed allows us to insert multiple fine bore catheters, allowing high flow rates of fluid with controlled reflux. The platform is a stable bone fixation platform, and that means that you can choose specific drug infusion ports, and this can be done over a long period of time. I didn't mention it, but the infusion system has inline filters to prevent any infection. And behind all this, of course, we have really quite impressive technology with software which ensures the likelihood of any problems associated with the procedures are kept to an absolute minimum. CED has been performed in Bristol with remarkable safety for over 10 years. The catheters that we have are currently in-house devices and are entirely specific to the team here. And our system, we think, is automated and reproducible and safe, and really as good as can be used anywhere in the world. We've treated 9 patients with DIPG so far and 3 adults, and we've seen responses in refractory disease. We've managed to repeat administration over several days and several weeks, even in outpatient setting in adults. And we think, more importantly, that whilst carboplatin and topotecan, of course, may be drugs which are of benefit to patients with these tumours, this is just the beginning, and that this is really an excellent platform for the development of many new clinical drugs in DIPG. I'd like to acknowledge the extensive team involved in this project. Thank you.